just
We
be
don't have to make
internal.
it publicly available.
Yeah,
Okay.
we could just share it. With
Yeah,
our
I just
group.
don't want to get in
Yeah,
trouble
yeah,
with
of
somebody.
course, of course. Yeah, so we could, I think what we could do is just, until we figure it out, we'll just share it within SCCR.
Okay,
And,
okay.
and I can share it with the BMT group.
Okay.
Or you can. And we won't post it on the website
Okay.
until we figure it all out.
Okay,
And-
that sounds fine.
Yeah.
And even if she hasn't signed the authorization, it's still going to
Yeah, no, this is
It
fine.
has nothing
We'll
to do
just have to make
After the
sure
fact.
that we get it from you later.
And are you comfortable here?
Yeah, I walk around a little bit, but that's good.
Oh, okay. Yeah, you can walk wherever you want.
Thank you.
I don't have a click.
That's okay.
I don't have a click. I had a mouse. That I
This
can
is
use.
usually, oh, right here.
No, the clicks don't work anymore.
That's all right. I can walk back and forth.
They've removed the chip.
Huh. Well, that's not
But I have
helpful.
a mouse that can be used as a click.
That's all right. It's just as easy.
That's fine?
Yeah. Yep, yep. Wow.
Susan's just going to introduce you. We don't really have any announcements, and
Okay.
it'll be all yours.
Yep. So I was listening to your fall on ice story. So I was home with a broken leg. So it's
From falling?
a horseback riding accident, but it's a tough recovery. So careful on the ice.
I know. Last year, I moved to Colorado last year. I've been there about a year and a half, and I commute. And I got these. They're like stretchy crampons for your tennis shoes. And I think this winter I'm just gonna wear them more because, that's the thing about falls, right? You can't plan for them. You don't expect them.
They're called accidents.
So there's actually two people.
It's okay.
No, there's room right here. And if we need to go get more chairs, we can.
Yeah, that's what I was planning.
You want to go ahead and introduce her, and then she can go ahead.
Oops, sorry.
Forgot that part. It's okay. I can take it off.
You can just introduce me as an old nurse.
Oh.
That's how I usually introduce myself.
What did you say?
An old nurse.
Would you like introducing your own self, like yourself?
I can introduce myself.
This is what I was going to read.
Oh, it's up to you. Whatever your routines are. But old nurse is kind of, it fits.
Always in BMT?
36 of my 40 years. Yeah.
Where were you for the 4?
I was in the Navy.
Oh, wow.
Yeah.
Oh, that's amazing.
Yeah, that was kind of an interesting experience.
Sure. Does everybody have a seat? We need to grab a few more chairs. Do you have one or no? No, okay.
differently. With us here, she's the clinical assistant professor of medicine in Division of Primary Care and Population Health at Stanford School of Medicine, and she's also an oncology nurse, clinical nurse. She calls herself old nurse.
I'm an old nurse.
And she's a specialist in the Division of Blood and Marrow Transplant and at Stanford Healthcare. And she has been caring for blood and marrow transplant recipients and their families for over 30 years. Her current research focuses on survivorship, including quality of life, social adaptation, and altered sexual health. So I am honored to introduce her, and I will pass on the torch to her and her presentation.
Thank you. So good morning. I've actually been caring for transplant patients now for close to 40 years. It's nice to have a younger picture there. So I need a little bit about your background. So tell me some of your backgrounds. Roles.
Research coordinators.
Okay, what else?
Research coordinator for stem cell division.
Okay.
Probably research nurses.
Some research nurses, okay. Okay. So data, okay. It's nice to see some familiar faces. So having been in the field of oncology for 30 years, I may throw out a term and fail to define it, and it might not be a term familiar to you. So I'd like your help if I do that to say, Kate, we don't know what that meant. All right? Can you help me with that? Yeah? Oh my, quiet group, we got to warm you up. Okay. So what do you want to learn today? You're all here bright and early and committed 2 hours of your time. You must want to learn something. No? So anything will do for you, okay? Anybody else have some specific things they wanted to hear about blood and marrow transplantation this morning?
I'm in the background of the BMT, and I don't know what happens in the forefront with the patient.
Okay, so some patient-focused thoughts. Okay, what else? Okay, well, you made it easy for me, so we'll go through my objectives for this morning. So I'm going to introduce you a little to the division, tell you a little bit about who we are. I'm going to talk about hematopoiesis, which is the formation of blood cells, because that's kind of the basis of what we do in blood and marrow transplantation. Talk about the types of transplants, the types of grafts we use in transplantation, how we determine who to bring into transplant, some outcomes, sort of the steps in the process, and a little bit about acute and chronic complications. Okay, so if there's something else that's not on that list, please ask questions, because I can probably address it even if I don't have a specific slide. So our program, Dr. Robert Negert is our division chief, is now celebrated 30 years last year of our program. And in 2017, we combined with the cancer cell therapy program, which was spearheaded here by Dr. Crystal Mackel. We did our first pediatric transplant in 1986 under the direction of Dr. Michael Amelon, and our first adult patient in 1987. And on November 2nd, just last week, our first adult patient celebrated his 32nd year post-transplant. And this is numero uno. And we have a patient reunion every summer, and our patients come back to celebrate life and hair and feeling better. And he gets to the mic every day and says, I'm numero uno, and tells us his story. And this is a photo of all the patients from our 30th reunion, or all that come to the 30th reunion. So it's a big program. You all work in big programs in one way or another. So you have a lot of different people that keep the things moving. So you have people on the back end that never see the patients, and you certainly have people that are interacting with the patients on a regular basis, and everybody in between. So most of you are in this box, the Clinical Research Associates. Is that a fair statement? Yeah, in the research? So we have now done about 76,000 transplants, and if you lump all the diseases together, about 50% of them become long-term survivors. So our first autologous transplant, where we use the patient's own cells, was done in 1988. Our first unrelated allogeneic using a donor transplant was done in 1991. Some of the people that keep this program moving are the financial people, and so in 1994 we formed an alliance with Northern California Kaiser. And Kaiser at that time was thinking about doing their own transplant program, and they approached us and said, if we give you an exclusive contract, will you do all of our patients? And that was a good deal for Stanford from a business point of view. And roughly 45% of our patients are Kaiser patients, Northern California Kaiser patients. And we meet with the Kaiser team twice a year to review quality issues, patient flow issues, workflows, to make sure that that alliance continues to move smoothly as we go forward. In 1997, we started doing autologous transplants for breast cancer, and that was a big move in the field because most of the diseases we treat in transplant, multiple myeloma, leukemias, Hodgkin's lymphoma, non-Hodgkin's lymphoma, comprise only about 12 to 15% of all cancers in the United States. So that's a pretty small percentage of the cancer burden in this country. But when we expanded to breast cancer, that was a big indication because breast cancer is a very common cancer. So we started doing autologous transplants for breast cancer in 1997. There were some studies that came out that showed no direct benefit, and so that population is not getting transplanted at this point. Let's see. In 2000, Dr. Robert Negrin took over as division chief from Dr. Carl Bluma, who was the founder of the program. We did our first haplotransplant, which is a mismatched related donor, in 2001. We did our first cord blood transplant using cord blood as a source in 2014. And as I said, in 2017, we started using immunotherapy, most commonly CAR T therapy, and the cancer cellular therapy program started at that time. So we make blood cells every single day. And I'll apologize if this is too basic because I don't know a lot about your backgrounds. But we make our blood cells in the bone marrow space, which is a sponge-like network of cells that support the development of blood cells. And as children, we make blood cells in the long bones of the legs and the arms, the pelvic bones, the sternum, the ribs, the backbone, the skull. But as we age, that blood-making space shrinks. So as adults, we make it primarily in the hip bones, a little in the sternum, the ribs, the vertebrae, and the skull. Okay? And this space is responsible for producing all the cells of the blood system and the immune system. All right? So we start way at the top of this cascade where we have a multipotent hematopoietic stem cell. And this cell is a very unique cell in the body in that it can grow up and mature into becoming lots of different cells of the blood and the immune system. Right? If you think about most of the cells in our body when they divide, they just replicate. They become a copy of themselves. So this multipotent stem cell at the top of this cascade is quite unique in that it has a lot of choices in life about where it's going to end up as an adult, if you will. So it first is capable of self-renewal, which is important because all of our blood cells have a limited lifespan. So we have to constantly renew. So we don't want to run out of stem cells because we, for a lifetime, need to continue to replace our blood cells. So it's capable of self-renewal, or it will start down a path of maturing into becoming functional blood cells. So its first choice is either become a lymphoid stem cell or a myeloid stem cell. If it goes down the myeloid path, it grows and matures to become platelets, which help control bleeding. It grows and matures to become a red cell, which carries oxygen around to our tissues. Or it grows to become a myeloblast, which differentiates into basophils, neutrophils, eosinophils. Or a monoblast, which when it enters the bloodstream becomes a monocyte. If it goes down the lymphoid path, it's either going to go down the natural killer path, and we'll talk about the function of natural killers, or the lymphocyte, where it will become either a T lymphocyte or a B lymphocyte. And principally, most of the diseases we treat in blood and marrow transplantation are a disorder where something went wrong in this maturation and division process. So most of the leukemias we treat are AML, myeloblasts. So something went wrong in the maturation of that myeloblast line that led to leukemic cells. Most lymphomas in adults are B lymphocyte diseases. About 80% of non-Hodgkin's lymphoma in adults is B cell, and about 20% is T cell. Okay? So most of the diseases we treat are something gone wrong in this division process. So we make about 1.5 billion white blood cells per kilogram of body weight per day. That's a lot of cells. And at the same time, we're making 2.5 billion red blood cells per kilogram of body weight per day. And we're making 2.5 billion platelets per kilogram of body weight per day. So if anybody in the room is really good with math, if your bank account did that just one day, you would all retire, right? That's a lot of cells. These cells have defined lifespan. A white cell only lives in the bloodstream, particularly neutrophils, live in the bloodstream for about 3 hours, and then they migrate into tissues to do their work, which is to fight infection, right? So, and a white cell only lives for about 8 hours. Red blood cells live approximately 3 months, so much longer lived, but eventually every 3 months we have to replace those red cells. And platelets live about 7 to 10 days. So again, we're constantly replacing that. That's a lot of division, right, in the bone marrow space. So you can see there's a lot of opportunity for something to go wrong. Right? Questions so far? No? I've got to get you guys talking.
Don't mind me. Just remove this because it seems
Oh,
from
sorry.
here, not everybody can see the bottom. Is that correct?
Anybody having trouble seeing the screen? I'll just keep moving to the corner.
No.
Okay.
I wish this was long enough to
Yep.
move you to the center,
Yep.
but it's not.
So T lymphocytes participate in hypersensitivity reactions like allergic reactions. They directly kill infected cells. This is their normal function. And they assist with B cell function. B lymphocytes synthesize and secrete immunoglobulins, become plasma cells. And immunoglobulins are sort of like our natural antibiotics. So plasma cells secrete a number of different immunoglobulins, IgG, IgA, IgM, IgE. And they all have different functions, but you can think of those as sort of our natural antibiotics that we secrete into our blood to help protect us from infections. Natural killer cells are a type of lymphocyte. They're very unique in that they don't need a specific target to be activated. So they can see any infected cell that looks abnormal and kill it, so a virally infected cell, or they can kill cancer cells because cancer cells look abnormal, and so they don't need a specific target, where B and T lymphocytes need a specific target on the cell that allows them to recognize that cell as infected or cancerous. Okay. Granulocytes, monocytes produce neutrophils, basophils, and eosinophils. In oncology care, we talk a lot about the absolute neutrophil count. And we're particularly concerned about neutrophils because it comprises about 60 to 80% of our total white blood cell count. And neutrophils are really important for fighting bacteria. And of course, our world is full of bacteria. So if we don't have neutrophils, we can get very sick very quickly. So we talk a lot in oncology practice about the absolute neutrophil count. And when we give chemotherapy and it drops the white count, if their absolute neutrophil count is below 500, then they are at high risk for serious infections. Right? Okay. Dendritic cells are what they call the professional antigen presenting cell. So if there's a virally infected cell, that cell puts a part of that virus on the cell surface, and the dendritic cell takes that and it presents that to the T cell and says, this is the virally infected cell and I need you to get rid of it. So it allows T cells to recognize the infected cell to destroy it. Okay? So it's a professional antigen presenting cell. Megakaryocytes, as I mentioned, help control bleeding. And erythrocytes are red cells and they carry oxygen around to our tissues. And we need a couple more chairs, I think. Yeah.
One of you can sit here and I will go get more chair.
So we recognize these different cells in the bloodstream in the immune system by the markers on their surface, and we call them the cluster of designation markers. And the one we think about a lot in blood and marrow transplantation is the stem cell. And so all stem cells have the CD24 marker on it. So you can see it's the 4th from the bottom is the stem cell, and it's got a CD34 positive marker on it. It's also got a CD31 negative marker. So when we're collecting cells from the donor, we want to collect enough stem cells that they're going to recover their blood counts after transplant. And so different cells have different markers. So the holy grail in oncology care is cancer cells also have different markers on the surface, is to find unique markers on the surface of the cancer that we can then target therapy to. Okay? So one of the first drugs to come out in search of that holy grail was rituximab, or Rituxan. It targets the CD20 marker. CD20 is found on it's found on all normal B cells, but it's also found on most B cells that are characteristic of non-Hodgkin's lymphoma. So we have a marker now that targets a specific antigen on the surface of the cell. Unfortunately, it's not a perfect, because normal B cells also have CD20. But it's getting close, and we're getting closer and closer to finding markers on the surfaces of cancer cells that we can target directly so that the normal cells aren't affected by our therapy, right? I mean, there's no reason you have to lose your hair to get rid of cancer. It's just that chemotherapy is not very selective, right? Chemotherapy in general works by attacking rapidly dividing cells. And the rapidly dividing cells in our system are blood cells, so our blood counts drop. Our hair is rapidly growing, dividing, so we lose our hair. The GI tract, the lining of the GI tract, is rapidly dividing every day. We slough our GI tract cells, so we see nausea, vomiting, diarrhea. So if we can find things that aren't so ubiquitous in their approach and find markers on the cancer cell surface, not found on the normal cells, then we have therapies that just affect the cancer, and we don't have to lose our hair or our GI tract, etc. Questions so far? Have I used any terms that I failed to define? Oh my. I have a feeling I'm going to have to do all the talking this morning. So as I mentioned, this is the same cascade, if you think about it. So most of the hematologic malignancies occur in that cascade of normal development of stem cells. So we have the myeloid disorders, AML, chronic myeloid disorder, and a hodgepodge of others. And on the lymphoid side, when things go wrong, we see acute lymphoblastic leukemia, chronic lymphoblastic leukemia, lymphomas, and multiple myeloma. Okay. So can we cure acute leukemia? And there's a few people in the room that should be able to answer this easily. Can we cure leukemia? Yes, we can. So in 1964, if you were diagnosed with acute leukemia, you probably would live 3 to 4 months. I know that's ancient history for some of you in the room. Some of us were actually alive at that time. So we now cure leukemia in a very short. So the first transplant was done in 1968 in France. There were about 3 done that year. The one in France was done for a child with severe combined immunodeficiency syndrome, which is somebody born essentially without an immune system. So you can imagine very susceptible to infections, and they kind of live in a plastic bubble. They have to be protected from the environment. The 1,000,000th transplant was done in 2012. So the history of transplantation is really only about 60 years old. So it's, in medicine, a relatively new field. So there was a sentinel paper published in 1975 in the New England Journal of Medicine, and they had 70 individuals that they transplanted for advanced leukemia. So these were people that had been heavily pretreated. Their leukemia was not under control. They probably had multiple infections and a lot of toxicity from prior therapy. So these were patients that in the vernacular would be really beat up, right, with bad disease. And 9 survived over a year. Now you'd look at that and say those are dismal odds, right? But it was the first time they could prove that you could cure even really bad leukemia in really beat up patient and they would survive. And in that same paper, 37 individuals with severe aplastic anemia were transplanted, and 16 of them became long-term survivors. And again, dismal odds, but it was the first time we had proof of concept that you could actually successfully transplant people and cure them of their disease. Okay. So for that work, Dr. E. Donald Thomas was awarded the Nobel Prize in Medicine in 1991. And Dr. Thomas is the gentleman with the white beard, receiving the award from the King of Sweden. So this is Nancy King McLean, and she is the first, the longest BMT survivor in the United States. So she had severe aplastic anemia, which is a disease of the bone marrow where you just don't make enough particular red cells. And her doctor was treating her with corticosteroids or steroids. And so she was suffering from all the side effects of corticosteroids, which if you've seen somebody on steroids for a long time, they get really puffy. They gain a lot of weight, their face gets really heavy. And she happened to go in with her sister one time to the doctor, and it turns out the mother mentioned that the sister was a twin. And you wouldn't know that to look at him because she was on so many corticosteroids. But the doctor decided it would be worth trying to take the twin sister's bone marrow and give it to her for her severe aplastic anemia to see if that would cure her of her disease. And she talked at our national conference about 2 years ago about her experience as a child being treated with a blood and marrow transplantation in the very early days of transplant. Okay. And right now, when we want to test the bone marrow, we put a big needle into this hip bone, usually from the back, and we pull out the liquid, and it tells us what's going on in that bone marrow. When she had her transplant, they went into the sternum. And she says she can still remember those sternal biopsies, which I would too, because if somebody were putting a needle in my sternum, I'd be thinking about all the stuff underneath, like my heart and my lungs, right? So we don't do that as often anymore. So there are different types of transplants. In an autologous transplant, the stem cells are obtained from the patient when they're in remission, and we freeze them, cryopreserve them, for administration following the high-dose chemotherapy. And the idea is, in cancer in general, you're limited to how much chemotherapy you can give by bone marrow suppression, because if you drop the counts too much, they're going to die from an infection or bleeding, right? So in transplant, the idea is you collect the stem cells first, bring them in for higher doses of chemotherapy with the idea of being more aggressive against their tumor, but to help their bone marrow recover from that high-dose chemotherapy, give them back their stem cells, and then they recover their blood counts. Okay? That's autologous. So in some ways, it's autologous rescue more than it is a transplant, because the cells come from themselves, right? In allogeneic transplant, the stem cells are obtained from a genetically matched donor, and the donor can be a relative, like a brother or sister. It can be a volunteer donor. Is anybody in the registry? Yay, thank you. I recently got kicked out. Or it can be cord blood. So umbilical cord blood can be collected after the birth of the child and frozen and stored for us as a source. And there are various degrees of genetic matching that you can use to select the donor. So I had been in the registry a long time, and I got called 3 times, but never selected for the dance, which is very disappointing. And they do age you out after a little while. And then syngeneic, the source of the stem cells is an identical twin. So Nancy King McLean, who I just showed you, her donor source was syngeneic. She had an identical twin. And of course, that's the least commonly performed type of transplant because most of us don't have an identical twin. Right. So these are slides from the Center for International Blood and Marrow Transplant Research. So they give a picture of our field across centers globally. So centers are required to submit data to the Center for International Blood and Marrow Transplant Research. They then collate that data, watch trends, compare outcomes, and they publish what they call summary slides every couple years. I did look Monday. This is the most current set of slides they have published. And we, as a center, are obligated by law to submit data to the Center for International Blood and Marrow Transplant Research. So you can see in the blue line is the number of autologous transplants beginning in 1980, and this truncates in 2016. And the green line is allogeneic transplants, donor transplants. And anybody remember what that spike in the 90s was from? I told you we started treating a very common malignancy. And so you can see there was this big spike because that's a common malignancy. But once the indication went away, the numbers dropped. Okay. So we can collect stem cells from a number of different places. Most of them, as I mentioned, live in the hip bones, right? And there's only a very small percentage that circulate in the blood. But we have means of getting those stem cells to move from the bone marrow into the blood so we can then collect those cells from the blood. And we call that process mobilization. We're moving the stem cells from the bone marrow into the blood so we can then collect them. And that process is called apheresis. If any of you have ever been a platelet donor, it's the same process. So you put a needle in one arm, blood's removed, spins through the machine, collects the cells, needle in the other arm returns the blood that you don't need for your procedure.
Can you elaborate on the mobilization?
I will in a moment. Thank you. Apheresis is performed as an outpatient. and it takes approximately 4 hours per procedure. We historically have collected cells from the bone marrow. So when I started in the field in 1980, that was the only source of stem cells. And so we collected them in the operating room. The patient would lie prone on the table, and the hematologist on each side of the patient would make about 6 pokes through the skin and the posterior iliac crest, and then they would angle the needle under the skin to keep withdrawing the liquid part, which is going to contain the stem cells. And so the patient would have a big bandage on their backside at the end of the day, and about 6 pokes through their bone and skin on each side of their iliac crest. And they didn't dance for about a week. It's painful. And then umbilical cord blood is collected after the birth of the child, and I have a slide showing that. So why would we decide to use peripheral blood versus bone marrow versus cord blood? And there are a number of advantages and disadvantages to each. So one of the advantages to peripheral blood is that the cells are slightly more mature when they get into the bloodstream, and so they recover their blood counts quicker. So their absolute neutrophil count recovers in about 10 to 12 days, compared to bone marrow, which takes about 21 days. So you can imagine that's a shorter hospital stay, that's a shorter period of time for infection, and that's decreased costs because you can get them out of the hospital quicker. Right? Platelet count usually recovers to about 20,000 within 30 days. So there's a decreased risk of infection when we use peripheral blood. There's less transfusion needs, shorter length of stay, and reduced costs, and potentially less tumor contamination. There's some disadvantages. The ways we move stem cells from the bone marrow into the blood require cytokine administration, which are growth factors that stimulate the release of stem cells into the blood. Sometimes we combine that with chemotherapy, so there's the side effects of the chemotherapy. You may not get an adequate collection. If somebody's been heavily pretreated, they've had lymphoma for a lot of years and they've been getting a lot of treatment over the years, they just may not mobilize their stem cells to get an adequate collection. For an allogeneic donor, the healthy donor giving marrow to somebody else, they may need a central catheter. If you don't have good veins, then you need a central venous catheter. Everybody knows what that is? Yes? Not sure? So if they've got good veins, if it's a healthy donor donating for a brother or sister, we put a needle in one arm, needle in the other arm. It takes 4 hours. A lot of times we'll get all the cells in one day. If they have tiny veins or not very good veins, then we might place a central venous catheter, which we can place in the arm, but it's a little more invasive, or we can place in the neck. And it's a much larger vein that we're going into, so we can get more efficient collection. Okay. So this is an apheresis machine, and if you can see behind the bag, there's some red fluid collecting. Those are the stem cells, and the stem cells are located in the layer between the platelets and the red cell. There's a plasma layer that will contain the stem cells and other types of white blood cells. So in adults, they process about 12 to 15 liters per hour at a flow rate of 50 to 100 milliliters per minute. So you need a big vein to process that quickly, that amount of blood. As I mentioned earlier, we use the CD34 cells to determine adequacy of collection. So our minimum collection goals is we want 2 billion stem cells, CD34 cells, per kilogram of body weight. So again, if you're quick with math, that's a lot of cells. And that many cells will be contained in about a cup of fluid. Lots and lots of cells. Common side effects during apheresis are hypocalcemia. We have to add an anticoagulant to the product and when we're collecting so it doesn't clot, and that can bind calcium. So your patient may complain of kind of tingling in the lips, sometimes in the fingertips. It means they need a little calcium, and we administer really expensive Tums, and that takes care of it. They can get hypovolemia because there's a fair amount, there's about 15% of their blood out of their system at any one time. Because it's not a precise science, this machine is working on centrifuging. So you will collect some platelets and some red cells. The patient may have low platelet count or anemia post-procedure, and headaches are fairly common. Bone marrow grafts, so you see this is a hematologist, this is the only procedure they're allowed to do in the operating room. They're not surgeons, but they're collecting from each side. And you can see in the syringe the dark red material. That's the stem cells pulling out of the bone marrow space. Okay. So there's less chronic graft-versus-host disease when we collect cells from the bone marrow, and I'm going to talk about that in a little bit. You don't need cytokines because most of our stem cells are living in our bone marrow, so you collect them in steady state. But there are, of course, risks associated with anesthesia, and there's postoperative pain. And they hurt the next week or so after this procedure. They will replace the blood cells we take within about a week. So they replace their cells very quickly because, as I mentioned early, this is a really prolific system, so we're making a lot of these cells every day. So it doesn't take them long to replace what we've taken. And then, please. So in most autologous transplants, we want to use peripheral blood stem cells because of all those advantages. They recover the counts quicker, they're in the hospital less time, less cost, less transfusion, less risk of infection. So most autologous transplants, we prefer peripheral blood. In the allogeneic setting where we have a donor, there's going to be a lot of different factors that help us decide what source of cells we want to use. It's going to depend on the stage of the disease. It's going to depend on the risks of acute and chronic graft-versus-host disease. So there's more variables to look at in the allogeneic setting. Right? So collecting Marin's question as well. So a physician in San Diego noted after he gave chemotherapy that the number of stem cells in the blood increased. It was one of those serendipitous kind of findings. And so as he looked more into that, it turns out that when you give chemotherapy, it initially suppresses the blood counts. But as the bone marrow starts to recover from that, it kind of overproduces. And what it's going to do when it's overproducing cells is release them into the peripheral blood. So what he observed is that after that chemotherapy, the bone marrow recovered, kind of overshot its target, and the extra stem cells were released into the blood. And so based on that observation, then growth factors were discovered that can augment that process to force the stem cells out of the bone marrow. And the most common growth factor we use is GCSF, or granulocyte colony stimulating factor. The brand names are Neupogen, if you've heard of that, or Neulasta. Some of you may work with Neulasta. And those are growth factors that tell the bone marrow make more cells. And so in some cases, we use just a growth factor to increase the number of stem cells in the blood. In other settings, we use a combination of chemotherapy and a growth factor to get more stem cells in the blood for collection. Did that address your question? Maren? Yeah? Okay. So if we're going to use growth factors alone, we give them for 4 to 5 days, and then we start collecting cells. And it's a subcutaneous injection, so it's not terribly invasive. And then we start collecting the cells on the 4th or 5th day. If it's chemotherapy plus growth factor, it's a little more variable when the blood counts we're going to recover. So those patients, we start checking their blood counts on a daily basis, and when it hits a certain threshold, we bring them back for collection. It is typically about 12 days after the chemotherapy, give or take. Right? So umbilical cord blood, in the far corner you can see the placenta with the umbilical cord blood. It's literally placed, elevated. The umbilical vein is cannulated, and the cells drip by gravity into the collection bag, which is on a rotator so that the cells don't clump. And there's a lot of advantages to umbilical cord blood because it's immediately available, right? It's sitting in a freezer in New York, is the biggest cord blood bank, right? There's no risks for the donor, right? This is a product that's discarded. The baby no longer needs it. And there's no risk to the mother because it's already been delivered. There's a greater degree of HLA disparity allowed between cord bloods and the recipient. So the way we select an allogeneic donor is based on some degree of genetic matching. And we use HLA, the human leukocyte antigen, to determine how well the donor and the recipient match genetically. And so it turns out because cord blood units are quite immature and naive, we can tolerate a greater degree of HLA disparity, so a greater degree of genetic dissimilarity between the recipient and the donor, and without an increased risk of graft versus host disease, which we'll talk about shortly. Please.
Regarding to this, how is this iterated in the case of bone marrow or peripheral blood?
How do we decide which one to use?
Or is there any difference as in umbilical cord?
So one of the disadvantages of umbilical cord blood is it comes from a tiny baby, so it's got a tiny number of stem cells. And so if I'm going to give a tiny number of stem cells to a full-grown adult, it's going to take a long time for that white blood cell count to recover, right? So the practice in so that's one of the key disadvantages to umbilical cord blood. The practice today is to give 2 umbilical cord bloods that are matched to each other and matched to the recipient. And so then you get a larger number of stem cells, so the recipients recover their blood counts faster, but still slower than if we were to give them bone marrow. So if it takes 21 days for bone marrow to recover, the range for somebody to recover after a cord blood transplant is anywhere from about 18 to 50 days. So the longer somebody's without white count, the higher the risk of infection. So waiting up to 50 days for the white count recover, you're pretty worried about infections, right? So the current practice is to use 2 units, and interestingly, for reasons that aren't entirely understood, both units contribute to the recovery of the white count, but one eventually goes away. And so the recipient's left with 1 cord blood unit that remains functional the rest of their lives.
Yeah, that was my question.
Okay.
Can we receive meat store?
Yes, yeah. So for a while there's both, and eventually one goes away. Do you work in the HLA lab?
No, I worked at BMT as an MD back in Russia.
Ah, okay, okay.
We had experience with cord blood double unit
Mm-hmm,
transplantation,
mm-hmm.
but only one.
One is a winner over time. Yeah. There's work now. We've participated in 1 study that's closed, and we have a second study that we're participating in where we're trying to develop an off-the-shelf cord blood unit that has lots of stem cells and can be used for anybody. So you're trying to get sort of a universal graft source, which would be amazing because then anybody that needed stem cells for whatever reason would have a source. So we are currently participating in a trial, and the patient is randomized to receive 2 umbilical cord blood units or this experimental off-the-shelf product.
What's the procedure to collect cord blood here? You have to request as a mother, or?
Yeah, it's all voluntary, and it's based on the request of the mother. It's not good to make that request in the middle of the delivery of the baby. It's best to know that in advance so that you can get the team there to collect the cells and then take them to the appropriate bank. Right?
It was a big deal several years ago for people to start banking their own baby's blood because of childhood malignancies. So if somebody chooses to bank their own umbilical cord blood for their kid, does that make it completely off limits for the rest of the world?
Yes.
So that's
Those are private cord blood banks. They store just for that individual, and there's monthly storage fees, of course, associated with that. So it's not available to anybody else.
okay. Yeah, that's interesting.
Yeah,
Unfortunately, interesting.
yeah. Lots of ethics there that we won't get into. Okay, so once the cells are collected, whether it's peripheral blood or bone marrow or cord blood, they're taken to the cell processing lab. We have an amazing staff in our cell processing lab. The product is tested for sterility and infectious diseases. We have to do ABO and RH typing. We try to reduce the volume of the product by removing primarily red cells so that we have to add less cryoprotectant. So you can't just collect cells and put them in the freezer because they would die during the freezing process. So you have to add a protectant that stabilizes the cell membrane so that you can freeze it and then someday thaw it, right? And so this is, if you reduce the volume, you have less cryoprotectant that you need to add, which has some toxicity. The most common cryoprotectant is DMSO, dimethyl sulfate oxide. I can barely say it. I know I can't spell it. And it's controlled rate freezing. So these cells are frozen slowly down to about 196 degrees, minus 196 degrees centigrade. And they're stored in liquid nitrogen. Okay? And there's a big freezer in the basement of Stanford Healthcare that contains lots and lots of these products, and it's alarmed better than Fort Knox. So if PG&E shuts off our power, a lot of people will know because that freezer is going to alarm very quickly. It's very important, right? Protect those cells. So this is looking at allogeneic transplants, so donor transplants based on the type of source in the United States. So the green line is HLA identical siblings. And you can say that line's been pretty flat for about the last 20 years. And that's because the probability of you finding a match within amongst your brothers and sisters is about 25%. That hasn't changed much over time. The darker blue line is unrelated donor transplants. And as the registries have gotten more volunteers in them, we're doing more unrelated donor transplants. And as we've gotten better at our typing and determining the match between the donor and the recipient, we are more able to safely do unrelated donor transplants. And then the orange line is other relatives, and these are relatives that match partially. And we call that haploidentical, which doesn't make sense to me because identical implies identical. But haploidentical means that they're a 50% match. They might be slightly better. And then the lighter blue line is cord blood as a source of cells. And that's starting to tail off because we've gotten better at doing these haplo transplants where there's a greater degree of mismatch. And all of us, in theory, would have a haplo donor, right? Any of my siblings would match me at least 50%, right, if we came from the same parents. My child would match me 50%. One of my parents would match me 50%. So if we look at haplo, it really expands the donor pool. So you're likely to find a match. And as we've gotten better at doing those, cord blood units are expensive. Not only do they take a long time to grow, which increases the infectious risk, but they're pretty expensive to procure. It's about $50,000 to $60,000 per unit. That's a lot of money, right? Okay. Questions so far? Yes?
So then, based on this, like aploidentical success, maybe is questioning like how important is the HLA matching, no, for success, or there might be something else.
So when we do human leukocyte antigen matching, when we do that genetic testing to determine the compatibility between its recipient and donor, we look at 10 major antigens. But there are a lot of other antigens we don't look at. And they're called minor histocompatibility antigens. And we don't test for those. So when we do a transplant from a brother or sister, we know that if they match on those major 10 because they came from the same parents, they're probably going to match on a lot of those others that we don't test for. But in the unrelated donor setting, that's not true. They could match on those major 10, but they could be very disparate in those minor histocompatibility antigens that we don't test for. So yes, there's a lot more to determining how well that matches other than the 10 that we test for. Did I see another hand? Okay. Okay. So in pediatrics, you can see in the blue, they use primarily bone marrow versus peripheral blood in the green. And in part, that's because children have tiny veins, so it's harder to collect using apheresis in tiny children or infants, right? So bone marrow is the source most commonly in pediatrics. And in the unrelated donor setting in pediatrics, orange is the cord blood, and you can see it's starting to drop off, and I think some of that's expense, some of it's the length of time getting the cells growing. Green is the peripheral blood, and blue is the bone marrow. And you can imagine the donor has a little say in this too. For those of you that said you're in the registry, if you get called, they're going to explain to you the risks and benefits of each procedure. Apheresis, you have to take a cytokine or that growth factor for 4 or 5 days, and then the apheresis procedure. Safe, but you're taking medication you don't need, and that may philosophically not feel good to you. And if it's bone marrow, it's anesthesia risks, and you're going to hurt for about a week, right? You're not going to get on your mountain bike that weekend because it's not going to be comfortable, right? In the adult setting, you can see we use primarily peripheral blood and less bone marrow. But like fashion, things swing back and forth. So bone marrow is back on the upswing a little bit because there are some advantages to bone marrow. And in the unrelated donor setting, adults, very few cord bloods for that reason I talked about. There's tiny numbers, and it takes a long time for those to reconstitute in an adult. And bone marrow and peripheral blood. So it looks like most donors prefer peripheral blood, right? Okay. Questions? No? Okay. So what kind of diseases do we transplant in with blood marrow transplantation? So the green is autologous transplants, the blue is allogeneic, and you can see in multiple myeloma it's principally autologous transplantation. We have done some allogeneic transplants, but there are higher risks associated. You can see in non-Hodgkin's lymphoma, again, the green, so mostly autologous transplants. Acute leukemia, myelodysplastic syndrome, the next three blue bars, really don't do autologous transplants for those. We use a donor. Hodgkin's disease or Hodgkin's lymphoma, primarily autologous, and then there's a smattering of other diseases. There are some other indications. There are non-malignant disorders that we do transplant for, such as severe aplastic anemia, which I mentioned earlier, Fanconi anemia, diamond blackfan anemia. These are principally diseases of childhood. But they can be life-threatening, so they may have a transplant. There's more work being done in autoimmune disorders. We just did our first scleroderma patient about a month ago, September. There's certain genetic diseases like Hurler syndrome, Gaucher syndrome. Again, these are diseases of childhood. I don't really know much about them, but they're treated by transplant. And then some solid tumors like neuroblastoma, very successfully treated with transplant. In the adult setting, we do germ cell tumors like testicular cancer. Any of the autoimmune disorders are a little tricky to bring to transplant because people with those autoimmune disorders can live a pretty good quality of life for a long time before their symptoms become a real big negative impact on their quality of life. And so transplants associated with some morbidity and mortality. So you don't want to treat somebody who might have another 20 years of good quality of life. So the real trick for autoimmune disorders is when do you intervene? Same with sickle cell. You know, their crises can be terrible, but in between that, they can live pretty functional, normal lives. And so you don't want to intervene too early and risk that they might die from your treatment when they might have had a number of years to go. On the other hand, if you get too late in their illness, they might not be healthy enough for a transplant. So the real trick with the autoimmune diseases is trying to determine when to intervene. Right? So we have not done any for rheumatoid arthritis because, again, that's a disease where people can live pretty functional, not to minimize the morbidity associated with rheumatoid arthritis, but we don't want to risk killing them prematurely. No, severe aplastic anemia is one of the diseases we do best with. About 80 to 90% are cured with the transplant. Somehow I don't think I answered your question.
pancytopenia is there, so we are giving the stem cells. So they differentiate and into all the...
And the blood counts normalize.
But further going on, the bone marrow needs to produce it every day, right? But their bone marrow is idiopathically suppressed. So for the rest of their life, how will they be suppressed?
So since we've replaced, in severe aplastic anemia, we've replaced their diseased bone marrow. So we replaced it with stem cells so they get their counts recovered, but we also give them the donor's immune system. So for a lifetime, it's the donor's cells that are producing all the cells of the blood and immune system. So we've gotten rid of the underlying problem with our preparative regimen, and we've replaced that diseased marrow with a healthy one from the donor. Was that the question? Yeah. Okay. Other questions? This is trends in allogeneic transplant by disease, and you can see acute myelogenous leukemia in the green line is the most common indication, and then the orange and the yellow, it's acute lymphoblastic leukemia and non-Hodgkin's lymphoma or Hodgkin's lymphoma. ALL, acute lymphoblastic leukemia, is the most common malignancy in childhood, so it accounts for about 30% of childhood cancers. The good news for children with leukemia is they're usually cured with standard chemotherapy. Most of them do not need a transplant. In adults, acute lymphoblastic leukemia is rarer, only about 30% of acute leukemia in adults, but it's a much more aggressive and difficult disease to treat in adults than it is in children. So how do we decide somebody can come to transplant? So we look at a number of things, including age. Although there's probably no hard and fast upper age limit. Although I can tell you when I started in the field in 1980, an allogeneic recipient over the age of 45 was rare. It was a really toxic treatment, and people over the age of 45 just weren't going to survive that high-dose chemotherapy and radiation. Right? Now we routinely treat people in their 70s. Right? And the joke in the field is that as the transplant physicians get older, the age of the recipients goes up. We look at comorbid conditions. Are they otherwise healthy? Is the only problem they have their leukemia? Right? If they have bad heart disease or bad lung disease or bad kidney disease, they're not going to survive high-dose therapy either. We look at Karnofsky performance status, or KPS. Does everybody know what that is? So that is a functional scale that ranges from 0 to 100. 0 is dead, and 100 means you have no limitations in your activities of daily living. Right? So for transplant, we want their Karnofsky performance status to be 70 or above, which means they might have some limitations because of their disease, but for the most part, they can carry on their activities. Okay? We look at organ function, so we do liver function tests, we do echocardiograms and MUGAs, we do pulmonary function tests. So we have to know that their organs are healthy so that it gives us confidence they'll survive the high-dose preparative regimen. We need to look at their support system. The allogeneic individuals, recipients, stay in the Stanford area for 3 months, and they have to have some adult with them that 3 months. So that's a big burden for families, right? If you're a 2-working family and now that couple has to be at Stanford for 3 months and they've lost probably both incomes, right? They might need somebody at home to care for their children or their pets, manage the house, pay bills. So it's a big burden for both the recipient and the caregiver to come here for 3 months. We have to look at finances. They have to have insurance clearance to come through. We want to look at previous therapy because all therapies have some toxicity. So we want to make sure that their previous therapy isn't going to predispose them in one way to a complication during transplant. So we have to look at the person, the recipient, and we have to look at the disease. Is it a disease that we can treat with transplant? What is the disease status? So I mentioned that sentinel paper published in 1975 where they took really bad risk patients and cured a small percentage. We now know that our success rates in transplant are much, much better if we transplant them when they're in remission. So we have control of their disease. If they're in induction failure, so they come in with active disease, or they're in relapsed, then our outcomes are much worse. So we want to get the patient when they're in remission because that's going to give us our best chance for cure. And we want to know that their disease is chemotherapy sensitive. So if they have lymphoma and you give them chemotherapy and their lymphoma just keeps growing, that means their disease is not chemotherapy sensitive. So just upping the dose is not likely going to help them, right? Because they're resistant. Just like microorganisms get resistant to antibiotics, cancer can become resistant to some of the therapies we give. So in that setting, we might not offer them a transplant, but maybe we'll offer them some immunotherapy like CAR T cells, right? So we try a different approach because chemotherapy isn't doing it. So if I'm diagnosed with, say, non-Hodgkin's lymphoma, that black dot in the chest is meant to represent my tumor. I'm going to get some therapy up front. The most common treatment for non-Hodgkin's lymphoma is R-CHOP, which is a combination of Rituxan and chemotherapy. And what we're going to want to see is that tumor shrink. And we're going to say if we can't find their disease on a CT scan or a PET scan or a bone marrow biopsy or peripheral blood, we're going to say they're in remission. So why wouldn't I say they're cured if I can no longer find their disease? I just got 6 cycles of R-CHOP to treat my lymphoma. My doc can't find my disease anywhere. But he says I'm in remission. I'm not cured.
Cells could be hiding out somewhere else.
Exactly. All of the tests we use to determine whether the tumor is gone have a level of sensitivity. And if the number of tumor cells is below that sensitivity, we don't see it. But we know by history of these diseases, if I stop treatment after those 6 cycles of R-CHOP, there's a good chance my disease will come back, about a 40% chance. So we don't know that it's gone. We just know we can't find it. Okay, so I have a B-cell non-Hodgkin's lymphoma. That's the most common lymphoma in adults. I get my 6 cycles of R-CHOP. I have no high-risk features to my disease. My doc says I'm in remission. He's going to watch me, or she's going to watch me. Right? I'm going to get a CT scan repeated every 3 months for the first 5 years to make sure my disease isn't coming back. About 40% of them after R-CHOP will relapse within 2 years. So 60% are probably cured, and another 40% are going to relapse. That's when we're going to discuss transplant with that patient with B-cell non-Hodgkin's lymphoma. Right? Because at that point, they've shown that chemotherapy isn't enough to treat their disease, standard chemotherapy. So in the autologous setting, we have to collect their cells first, so they're in the freezer, and then we can bring them back for higher doses of chemotherapy. So a common combination is Rituxan, a monoclonal antibody, targets CD20, plus Cytoxan, a chemotherapy. And nursing care around that time is about safely administering those agents, managing self-care, symptom management, patient and family support, because these patients get this therapy and they go back to their home communities. So we have to teach them very carefully how to take care of themselves and when to call us if there's trouble. And then we start checking their labs, and when their white count gets to about 3,000, we check their CD34 count, and if it's above 10, we start collecting cells, and that's the apheresis process. And then those cells are taken to the lab, and they're frozen, and then we bring them back for transplant. So we always talk about day 0, the day of transplant as being day 0. The days before that are negative days. So the patient's going to be admitted to the hospital on day -6, and they're going to get chemotherapy. In this case, it's carmustine or BCNU. A day of rest, that's not about sleep. That just means they don't get any chemotherapy, because everybody knows you can't sleep in a hospital. On day -4, they get a chemotherapy drug called VP16. These are all high-dose chemotherapies. Another day of rest, dose of Cytoxan, rest, and then transplant. And so up front, the nursing care, again, is safely administering that preparative regimen. These are high-dose chemotherapy agents, so there's no room for error. Symptom management, patient support, education. On day 0, we infuse the graft. And then while we're waiting for engraftment, the recovery of the white counts, we're looking at bone marrow suppression. So they're at risk for infection, and there's a lot of things we do prophylactically to prevent infections, symptom management, and they get transfusions, platelets and red cells, to support them until their blood counts recover. Okay. And so this is Dr. Carl Blume infusing autologous cells. So back in the day, we did it by gravity. We no longer do it by gravity. We use pumps. We've come a long way. This woman was being treated for Hodgkin's lymphoma. Up front, about 80% of people with Hodgkin's lymphoma are cured with standard therapies. So 20% of people with Hodgkin's lymphoma will come to transplant. And her goal at the time was to see her 2 middle school children get through high school. Well, they made it through high school, and she was still alive and well. And then she wanted to get them through college. So she got them through college, and she's still alive and well. And now she's taking care of grandchildren. And she gave me permission to share that story. Do you usually give people a break, or you just keep plodding along?
It's totally up to you.
Do you all need a break? Yes, please.
So, for like oncology patients, is it almost always blood and marrow transplant in conjunction with high-dose chemotherapy?
Yes.
Like those two almost always?
In the autologous setting, it's always high-dose therapy, and then you give the cells back. And you can think of it as a rescue in the autologous setting. We're rescuing the bone marrow from that high-dose chemotherapy. Did that answer your question? Yeah? So do you need a 5-minute break? Okay, well, if you need to, you can just leave, since you're not going to tell me what you want. So the primary cause of failure of autologous transplant is relapse disease. So for those that have an autologous transplant, the risk of relapse disease depends some on the disease and the risk factors that come with their disease, but that's the primary cause of failure or death. And you can see infection counts for the next biggest chunk of people that succumb for allogeneic transplant. And outcomes, for those of you that like grafts, for multiple myeloma, the probability is a 3-year survival. Now, keep in mind that doesn't say cure, that says survival. So multiple myeloma is one of the few diseases we treat where the goal is not cure, because we do not believe we can cure multiple myeloma. But what we know is we can buy them on average 3 to 5 years of remission where they don't need therapy, which improves their quality of life. So that's the one indication where cure is not the goal. In the other diseases we treat, we're really shooting for a cure, which is important because it helps justify some of the risks the patient's going to take to undergo transplantation. And so in non-Hodgkin's lymphoma, diffuse large B-cell, the most common, if they have chemotherapy-sensitive disease, so we give chemotherapy, the disease still shrinks, they have about a 62% chance of 3-year survival. And if they survive 3 years, they're likely cured. If they have resistant disease, right, like those first early patients we treated, then the odds drop almost by half. And that's true for mantle cell lymphoma, follicular lymphoma, Hodgkin's disease. Acute myelogenous leukemia, we don't do many autologous transplants for here at Stanford, but our neighbors to the north, UCSF, does a lot of transplants for AML. So it's not unheard of. And this is also data from the CIBMTR. Questions? Okay. So this is that human leukocyte antigen that I've been talking about. So we inherit a haplotype from our mom, and we inherit a haplotype from our dad. Right? So you can see the father has 2 haplotypes, 1, 8, and 10, and 3, 14, 17. Mom has 2 haplotypes, 2, 7, 11, 10, 15, 16, and 8. And so all the siblings are going to inherit some combination, 1 haplotype from mom, 1 haplotype from dad. So you can see the person in the middle got 2, 7, 11 from mom and 3, 14, 17 from dad. And her brother is a match. Oh, no, wait a minute. Where's the match? 2, 7. Oh, yeah.
Brother is matched to you,
Yeah, brother's matched to you. Okay. So we only 25% of patients who need a transplant will have a sibling match. Right? So example A, so these are the different alleles we test at low resolution, A, B, C, and DRB1. And then high resolution adds DQ, just different levels of typing. So in the first A example, everybody matches on everything, so that if they match on everything up to DRB1, it's an 8 out of 8 match. If we match on DQ, it's now a 10 out of 10 match. And that's the goal when we select an unrelated donor, is a 10 out of 10 match. In example B, they mismatch on 1A antigen, and so that's a 7 out of 8 match. If we do high resolution typing to look at DQ, they're now a 9 out of 10 match. And we do 9 out of 10 matching. So we will select somebody much below that. You're going to run into problems during the transplant because of that mismatch. There are currently about 13.5 million donors in the registry. The biggest registry in this country is Be the Match, which is run by the National Marrow Donor Program. It was initiated in 1986 by the Department of Defense. So why would the Department of Defense be interested in a volunteer pool of donors?
Because a lot of soldiers alive.
Following nuclear accidents. So nuclear war, nuclear accidents. So they really wanted a pool of donors for our Marines and sailors and soldiers that are in harm's way. So there's about 13.5 million donors. They have about over 200,000 umbilical cord bloods stored, and they facilitate about 10,000 transplants a year. Right? There's also a very large registry in Germany. We get a lot of donors from Germany. And I think there's a bigger public push in some countries to get people into the registries. So just when you think you understand HLA typing and how it all works, we had a Hispanic man who had a transplant, and his donor was from Germany. And that kind of surprised me because I don't know how many Hispanics in Germany are in the pool. It talks to genetic diversity. He lost his graft. After a little while, his graft wasn't working, so we looked for a second donor. His second donor was from Germany. So just when you think you understand it. So your odds of finding a donor in the registry, depending on your ethnicity, are 75% or above. So we can find matches for a lot of people. But it really depends on your ethnic background. So if you can find high-resolution matching for about 75% of Caucasians of Northern European descent, but only about 16% for blacks of South or Central American descent. So there's a big disparity based on racial backgrounds. And most of the efforts now in the court and the volunteers is to get more ethnic diversity into the pool. And so you can imagine as there's marriages between different ethnicities, that gets harder to find donors, right? So if dad's American and mom's Vietnamese, it's going to be hard to find a match for that child, right? And for cord bloods, because we can tolerate more HLA diversity or discrepancy between recipient and donor, we can find a cord blood unit for almost all patients under the age of 20, and for about 80% of patients over the age of 20, regardless of ethnicity or racial background. So how do we select the donor? History and physical. You have to have a healthy donor. You don't want to put your donor at risk. This may be a brother or sister, but this may be a volunteer, but this is a healthy individual and you don't want them to have problems. So history and physical exam, blood testing. We look at infectious diseases because those can be transferred from the donor to the recipient. So we look at hepatitis, HIV, syphilis, Chagas, cytomegalovirus, CMV. They get an X-ray and EKG. They get pregnancy testing. We don't want to give a pregnant woman growth factor because there may be untoward effects on the child. And then the HLA typing. What would be an absolute contraindication for a donor? Immunodeficiency or cancer. Yeah. We do sometimes take donors who have a remote history of cancer where the oncologist is sure they're cured because, again, you can transfer malignancies through this process. If they go to a bone marrow harvest, they're going to be discharged usually the same day if the surgery was early enough in the day. They should not soak in the tub for a couple days. They'll replace their cells within a week or two. The most common complications, this was from a study of 1,500 donors, was low blood pressure because of the volume of blood removed. About 14% need a transfusion. In many centers, they'll collect an autologous unit from the donor before the surgery so that if they do need blood, they get their own blood back so you don't expose them to the low but risks of blood transfusions. Pain, fever, and psychological distress. Donors suffer a great deal if the recipient doesn't make it or has complications.
What time point they allowed to know if patients survive?
Generally, it's about a year. If it's an unrelated donor, about a year. If both the recipient and the donor agree, they can exchange information. That's facilitated through Be the Match. If it's a sibling, they'll know right away. And the 3 times I've been called as a potential donor, the first question I had is this a Stanford patient? Because it would be very hard to maintain anonymity. And then this was the times I was called, this was a time when we only used bone marrow. And so I was very worried about going to the OR and exposing my backside to my boss. So I was going to take a nurse with me. Make sure there were no comments made. If it's, we collect peripherally, they get the growth factor for 4 to 5 days. The Neupogen, the growth factors are pretty well tolerated. They cause bone pain, like an achiness and throbbing in the bones, particularly the hip bones, and headache are the most common side effects. Rarely they can be enlarged spleen, flu-like symptoms. Those are usually pretty manageable for most donors. And then rarely they'll need a central venous catheter, but they have the same issues with psychological distress. If the patient doesn't do well, they have a sense of guilt. Doing okay. So when do we do an allogeneic transplant? Well, in allogeneic transplants, we want to replace the diseased or non-functioning marrow by administering a preparative regimen followed by infusion of healthy donor cells. So replacing diseased or malfunctioning marrow. Or we want to provide immunosuppression to allow replacement of the host's immune system with a healthy immune system from the donor. So the goal is immunotherapy, and the healthy donor immune system recognizes and destroys the disease. So in the first setting, we're relying on the preparative regimen plus the healthy donor immune system. In the second setting, we're relying just on that immune system. So we learned a long time ago that part of the cure in allogeneic transplant comes from that new healthy immune system. I think maybe that's actually the next slide. So again, this is a long time ago, 1980. We noted that the risk of relapse on the y-axis, as you go up, higher risk of relapse over time. For patients that had acute and chronic graft-versus-host disease, which is a reaction of the donor immune system against the recipient, they had a very low risk of relapse. Where if you did syngeneic transplant from a twin, they had a high risk of relapse. And so what we know is that new immune system from the donor can recognize residual tumor and destroy it. Okay? And you don't have that in a twin because you're essentially getting your same immune system back. Right? So it's that new immune system from the donor that can contribute to cure. Right? And so this paper was published in 1990, but George Mathey, a physician in France, started writing about this immune response in the 1970s. So they've known for a long time that that donor immune system was part of the cure. And we call that the graft versus tumor benefit. Okay. So in the allogeneic setting, that black dot is the tumor. They get some upfront therapy before they ever come to transplant. Try to get them in remission. That's the ideal state to come into transplant. And while we're working on that, we're also trying to identify a donor. And one of our efforts when we work with our community physicians is as soon as they think this may be a transplant candidate, let's start looking for a donor. Right? Don't wait until their first consultation with us. Start the HLA typing on the siblings right away. Do a preliminary match in the unrelated donor registry. Don't wait for that first consult. So the purpose of the preparative regimen, the chemotherapy and or radiation given to prepare them for the donor cells, is to eradicate the disease, eradicate the non-functioning marrow, and immunosuppression. And we select the preparative regimen based on their disease and their prior therapy. Right? So I couldn't give you any donor cells today without a preparative or conditioning regimen because you would all reject those donor cells immediately. Your immune system would say, no, 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 not mine, don't belong, you'd reject those cells. So we have to prepare you to get those donor cells. Allogeneic preparative regimens come in 3 flavors. Myeloablative, we completely wipe out or ablate the recipient's blood and immune system and replace it with the donors. Right? So if we don't give them donor cells and we've given them myeloablative conditioning, they're going to die from bone marrow failure. So we have to give them the donor cells. Reduced intensity. The preparative regimen, the chemotherapy or radiation up front, suppresses the host immune system, but it doesn't completely eliminate it. So if we didn't give donor cells, we would think with time the recipient's blood system would recover. It might take a long time, and they might get an infection in the interim, but eventually their own counts would recover. And then non-myeloablative conditioning, what we give to prepare them for transplant, only suppresses the host enough to get the donor cells to grow. And in the non-myeloablative setting, the cure is coming not simply solely from that donor immune system. So in that setting, non-myeloablative, we're relying 100% on those donor cells to recognize tumor and get rid of it. Okay. Did I lose anybody? So one of the docs that's no longer with us called this the 3 chili approach to transplantation. So the non-myeloablative is kind of a really mild chili, and then reduced intensity is 2 chili, a little hotter, and then myeloablative is 3 chili transplant, really hot, okay, in terms of intensity. So in the ablative conditioning, we get a very potent anti-tumor effect from the conditioning, the chemotherapy and radiation, and we get the graft versus tumor benefit of the new immune system. In reduced intensity, we get a modest anti-tumor effect from the conditioning regimen, the chemotherapy, and we get graft versus tumor benefit. And in non-myeloablative, that conditioning regimen really has no anti-tumor effect. we're relying 100% on the graft versus tumor benefit.
Could you talk about the ways in which you choose amongst those regimens?
Mm-hmm.
You're probably going to do that, right?
I am, but thank you for the clue. Actually, I've got some case studies. Maybe you'll decide. So what this graph shows is different conditioning regimens, and as we move to my side of the graph, the chemotherapy is getting more intense. These are just different combinations of chemotherapy or radiation. As the preparative regimen gets more intense, we get more toxicity, not surprising. And as we go up, we're relying less on the graft versus tumor benefit. So way down here where they just get TBI, total body irradiation, it's not very intense, doesn't have a lot of toxicity, and we're relying solely on the graft versus tumor benefit. But way at the top, if we give busulfan and Cytoxan, 2 types of chemotherapy, plus total body irradiation, it's very intense in terms of dosing, a lot of toxicity, and we're not relying so much on the graft versus tumor benefit. So these are some of the different chemotherapies we use. If you think about oncology, there are hundreds of chemotherapy drugs, hundreds of them. But the list for transplant is pretty small, right? So all chemotherapy drugs have dose-limiting toxicities, right? So if you give too much, you're going to have some toxicity that's no longer acceptable. So for etoposide, the dose-limiting toxicity is mucositis. If you give more than a certain dose, they're going to get horrible mucositis, have airway problems, may need to be intubated. So you have to keep the dose below that. For adriamycin, a very common chemotherapy drug in oncology, the dose-limiting toxicity is cardiac. If you go above a certain dose of adriamycin, you're going to destroy their hearts. They're going to have cardiomyopathy. So in transplant, the dose-limiting toxicity of most of these agents is bone marrow suppression. And we're not so worried about that because we're going to replace their bone marrow. We're going to either replace their bone marrow with cells we collected from them in the autologous setting, or we've got a donor standing by to give us cells. So we're not worried so much about that myelosuppression. So it's a pretty short list of chemotherapy drugs that we give in transplant. And we give different flavors of radiation, total body irradiation as 1 dose, fractionated total body irradiation, bigger dose of radiation but delivered in fractionated doses over a number of days, or total lymphoid irradiation, which is radiation just to the lymph node areas of the body, which provides profound immunosuppression. Immunosuppression is important to allow the donor cells to grow. So we have different flavors. And then we like this drug, antithymocyte globulin, because it is immunosuppressive because it kills T cells, so it facilitates the donor cells growing. And it stays in the body a long time, so it does help protect against graft versus host disease. So this is a myeloablative transplant. They get a big dose of radiation over 4 days, 1,320 centigrade. They get 2 days of Cytoxan, again, a big dose. They get that day of rest, and then we infuse the donor cells. Early on, we're waiting for engraftment, and during that period of time, it's about infection prevention, transfusion support, symptom management, patient family support. And then for the next 3 months, we're worried about graft versus host disease, which is an immune reaction of the donor cells against body tissues. So the graft versus tumor benefit is when that new donor immune system recognizes tumor and kills it. Graft versus host disease is when that new donor immune system recognizes recipient tissues as foreign and tries to attack body tissues. Okay, so the benefit is graft versus tumor, the risk is graft versus host disease, and that is one of the biggest challenges we have in allogeneic transplant. Reduced intensity, they get a normal dose of fludarabine, a type of chemotherapy, a single dose of total body radiation, but small. This is 200 centigrade. In the ablative regimen, it was 1,320 centigrade, so big difference. And then infuse the graft, and again, pretty similar care post-transplant. So one of the advantages of reduced intensity, so these are pretty much standard dose chemotherapies, is that we can now treat older individuals. So I mentioned when I started in the field 100 years ago, if you were over 45, that was old for an allogeneic transplant. We now use this kind of conditioning, these standard dose chemotherapy conditionings, in people into their 70s. So we can treat older people. And that's important because most of the diseases we treat, leukemia, multiple myeloma, non-Hodgkin's lymphoma, occur in older individuals. Right? So now we're treating people that are more likely to be diagnosed with these diseases. Because it's reduced intensity, if they have a little bit of organ dysfunction or a comorbid condition, we can still usually safely get them through it. And we can treat people who have had a lot of chemotherapy in the past because they're going to tolerate this regimen better than high-dose chemotherapy and radiation. There's less bone marrow suppression, there's less organ toxicity, and there's lower non-relapse mortality. But there's a trade-off. What do you think happens if you reduce the amount of chemotherapy you give up front? Right, higher risk of relapse, absolutely. Yep. So the disadvantage is remission status is critical to success, and you're trading off with a higher risk of relapse. Right? This is our non-myeloablative regimen. It's a combination of total lymphoid irradiation, TLI, and antithymocyte globulin. It's being given over a 2-week period solely to suppress the recipient's immune system, so when you give them the donor cells, they'll let those donor cells grow. Right? So it's all immunosuppression. And this is done as an outpatient. It's really well tolerated, even in our elderly population. When I give chemotherapy to somebody, I get tumor kill instantly. That chemotherapy, as soon as I infuse it, is going to start killing cancer cells. In this setting, I'm relying on that donor immune system. Right? It takes a month to 2 months for that donor's immune system to begin to grow and function. Right? So I can't use this approach in somebody with active disease because while I'm waiting for the donor immune system to grow, their cancer is taken off. So these people have to be in remission to start with because I need time to get that donor immune system to grow and function to provide that graft versus tumor benefit. Make sense? Yep. Okay. So this is on day 0. We infuse the cells intravenously. We had a woman we transplanted many years ago. Her father was actually a professional cartoonist. He drew a lot of pictures of our staff and the process, and I still use them. This is very old. But we infuse these cells, these little stem cells here, and some will go off to the liver and some to the spine, some to the lung. You can see a couple in the middle trying to decide what path they want to go down. These cells will home to the bone marrow eventually and start producing cells. I used to think of this process as kind of magic. These cells were smart enough to get back into the bone marrow and do their work. I made the mistake of saying that to Dr. Bluma one day. So remember, he's our founder of our program. And, oh, no. He brought me a paper to my office. And he said a physician in Germany discovered how these cells home in. So I left the paper on my desk for a few days, and then I returned it with a little note, said thank you. Never read the paper because I still like the magic theory about how these cells find their way into the bone marrow. I've since had to learn, but anyway. So nursing care for these patients is really complex because they are dealing with a lot of problems every day, and they overlap, and your treatment for one problem may contribute to another. Okay? So the timeline's on the bottom. They get their preparative regimen or conditioning regimen. Day 0 is transplant, waiting for engraftment, the cells to grow, and recovery. So starting with the conditioning regimen, they have nausea and vomiting, anorexia, loss of appetite, dysgeusia, which is taste alterations. Up front, it's because of the chemotherapy. As we move on, it's often because of the antibiotics. Mucositis is irritation, inflammation, sores that line the mouth and throat. And that, for many people, is the most painful part of their transplant because it hurts to talk, hurts to swallow. So pain control is a big part of the nursing care. And then our mouths are full of bacteria, and we don't want that bacteria getting through that broken barrier into the bloodstream to cause infections. So really vigorous mouth care to minimize the risks of infection. Neutropenia, low white count, high risk of bacterial infections. Thrombocytopenia and anemia. And you can see they're all overlapping. And integumentary skin toxicities, a lot of rashes from chemotherapy and antibiotics. Acute graft-versus-host disease. Every drug we give is cleared from the body by the kidneys or by the liver. So both usually take a hit during transplant because we're giving a lot of antibiotics, and it's either going to impact the liver or the kidneys. So we see changes in kidney function and liver function. Diarrhea is a very common manifestation of the preparative regimen, the chemotherapy. It also can be caused by infections. Sinusoidal obstructive syndrome is a problem where the liver gets congested, blood doesn't flow through it freely. It occurs in about 21% of transplant recipients, and it can be fatal in about 3 to 4%. And then we see different lung problems, and then psychological distress, anxiety, depression, isolation, family concerns, financial concerns, and relationship distress. So that just overlays every aspect of transplant. This is a scary time for patients and their families. And so you can see on, say, about day 14, day 8, you're dealing with almost all of those problems, right? And so fixing one often makes another one worse. So it's very complex nursing care. Causes of death in the, let's see, in the first 100 days, primary disease in about 27%, matched by infections in about 27%. And then beyond day 100, still a risk of relapse from the primary disease, but the risk of infections drop, and now we're worried about graft versus host disease. So this slide shows that concept of treating people earlier in their course of the disease. So these are outcomes for patients with acute myelogenous leukemia with a sibling donor. If we treat early in the course of their disease, the blue line, they have about a 65% chance of long-term disease-free survival. If they have active disease or advanced disease, then the success rates dropped. So in that first 1975 paper, where 9 became long-term survivors, they were in this advanced group. So still the outcome isn't 0, but this is a tough group of patients to treat successfully. This is for myelodysplastic syndrome, which is where the bone marrow just isn't producing cells normally, and those that it does produce are dysplastic. They don't look normal, and so they don't function normally. And so again, early in the course of the disease, better than wait till they're advanced. This is the same story for acute lymphoblastic leukemia. Earlier is better than late. And for severe aplastic anemia. So these bars are pretty high. So this is really the disease we do best with. It is a very rare disease. So I'm not going to spend a lot of time on acute graft-versus host disease because I don't think it will be that as interesting to you, and it's not really it's not part of the principles of transplant. But are there any questions before I move on? Thoughts? Yeah, yeah, please.
Cost associated with donors.
Mm-hmm.
Is that covered by donor insurance or
Recipient.
it is? Okay.
Yeah, that goes.
Does that make sense?
Yeah. So the donors, the costs related to donor procurement and care go to the recipient's insurance. Yeah. Acute graft-versus disease. So the benefit of that new donor immune system is the graft versus tumor benefit. So we know that that donor immune system can recognize residual tumor and destroy it. But it can also recognize host tissues and destroy host tissues. And the old view was that the donor T cells simply just reacted against host tissues. But we now know it's a really complex problem that's mediated by a number of cells, cytokines, chemokines, adhesion molecules, and signaling pathways. And so we think of acute graft-versus host disease as a 3-step process in terms of pathophysiology. The first is the tissue damage created by the conditioning regimen. So when we give high-dose chemotherapy, we do a lot of tissue damage. That's why they get mucositis, the GI tract. And when we damage tissues, those tissues release a lot of cytokines. And what do cytokines do? They activate the immune system. So now those cytokines that are released in response to the preparative regimen or the conditioning regimen are activating the donor immune system. It's seeing these cytokines and it thinks, oh, there's an infection. I need to take care of the infection. That's the way the donor cells read it. Step 2 is then once those cytokines are released, the donor cells are activated and they clonally expand. They increase in numbers because they think they have a big infection to take care of, because that's normally what releases cytokines in our tissues. And then step 3 is the damage to tissues caused by all those inflammatory cells. And this is just a way of looking at it, and I'm sorry I included it, because I don't like it when speakers put in a slide and then don't talk about it, so I apologize. So we know that acute graft-versus host disease is really an exaggerated and dysregulated response of that normal donor immune system to to tissue damage that's intrinsic to transplant. The donor's immune system basically thinks there's an infection and I have to get rid of it, right? The acute graft-versus-host disease affects the skin, causing rashes in varying degrees of severity. The liver increases bilirubin and can lead to liver failure, and the GI tract, diarrhea or vomiting, and in later stages that diarrhea gets very profuse, liters per day, and can get very bloody. And less commonly, acute graft-versus-host disease affects the spleen or the lung, kidneys. So this is a rash that's pretty characteristic of acute graft-versus-host disease. It's maculopapular, it's erythematous. When you push on it, it will blanch. And in severe cases, they get bullous formation. They look like burn patients in very severe cases. Fortunately, we do not see that very often. And in the liver, we see increased bilirubin, and if you do look under the microscope, you see damage to the caniculi of the liver. I have never looked under a microscope to look at acute graft-versus-host disease, but that's what they say it looks like. And the GI tract is all convoluted, right? It's loops and loops and loops, a bowel. And there's all these little ciliae, hair-like fibers that project into the lumen of the bowel. And those little cilia are responsible for absorbing water and nutrients and nutrition into the bloodstream. So in graft-versus-host disease, that GI tract becomes denuded. You lose all those little finger-like projections, and it looks like a smooth pipe. So if you put things through a smooth pipe, you get diarrhea. There's nothing there to absorb the water or the nutrients. And so it's just like you lose all those folds, all those ciliae, and nothing can be absorbed from that GI tract. So we stage each system individually, and then we look at the involvement and come up with an overall grade. Grade 1 to 2, acute graft-versus-host disease, we can almost always successfully treat. Grade 3 to 4 can be life-threatening. And the risk of life-threatening acute graft-versus-host disease, even with a fully matched sibling donor, is about 10%. So even in a fully matched situation, you still can get graft-versus-host disease. Risk factors include HLA disparity, so the bigger the disparity, the higher the risk. Increasing recipient and donor age. The intensity of the preparative regimen. If I give a fully ablative regimen, high dose chemotherapy and radiation, a lot of tissue damage. If I give a non-myeloablative, not so much tissue damage, it lowers the risk of graft-versus-host disease because that upfront preparative regimen causes tissue damage. So the less intense that preparative regimen, the less tissue damage, the less cytokines released, the less activation of the donor immune system. Prior infections, donor gender. So we know that males who receive have a female donor, have a higher risk of graft-versus-host disease. And there's two theories to that. One is when a woman's pregnant, she's exposed to the foreign antigens of the baby. And so her immune system's a little more sensitized to foreign antigens. So in the wisdom of our systems, the woman doesn't reject her baby, but her immune system now knows what a foreign antigen looks like. And so that's one theory, so that female's immune system is a little more sensitized. And the other is that the female donor actually may recognize the Y chromosome on male cells, and that may be why there's a slightly higher risk of graft-versus-host disease for male recipients with a female donor. So we often don't have a choice in donors. We find a donor. But if we have a choice, that would be one of the things the physician would think about whether they wanted to give select a female donor or a non-pregnant female donor. Donor parity we just talked about, and graft source. So we know that when we use bone marrow, there are less T cells that are collected. And so T cells are what are responsible for graft-versus-host disease. And so bone marrow is associated with less chronic graft-versus-host disease. When we collect cells from the peripheral blood, we collect more T cells. So there's a higher risk of chronic graft-versus-host disease when we collect from the peripheral blood. So the source of the graft is also going to influence the risk of graft-versus-host disease. So we're always balancing this graft versus tumor benefit, which we want to preserve, versus preventing graft-versus-host disease. So it's always a balance. So the first way to prevent graft-versus-host disease is HLA matching. The closer the match, the lower the risk. The mainstay of prevention is immunosuppressive drugs. We currently use a calcineurin inhibitor with methotrexate as the gold standard. Well, if T cells cause graft versus host disease, why don't you take them out of the graft, right? And then you'll reduce your risk of graft versus host disease. And in fact, they did that experiment 20 years ago, and if you take away the T cells, you definitely decrease the risk of graft versus host disease. But turns out T cells are important for other things. One, they're important for engraftment. So if you take away the T cells, the patient's less likely to recover their blood counts. T cells are an important part of our immune system. So if you take away T cells, I'm now more susceptible to infections. And T cells are principally responsible for that graft versus tumor benefit. So if you take away T cells, you now increase the risk of relapse. So just taking away all the T cells, what sounded on the surface of it a great idea, turned out not to be a great idea in clinical practice. Infection prevention. So the way I talk to patients about this is, I say, so you've got this new donor immune system, and we're giving you tacrolimus and methotrexate. We're essentially trying to keep your new donor immune system quiet, asleep. An infection is an alarm clock. It's going to wake that immune system up. Appropriately, the immune system will rev up to take care of the infection. That's its job. Now it's awake, it's revved up, and it's looking around saying different house. So it's not unusual. People have evidence of an infection, and a week later we see graft versus host disease. So preventing infections is really key in preventing graft versus host disease. So I already said that. So, and I said this, so if we take away T cells, T cell depletion, we decrease acute graft host disease, but we increase our risk of relapse and delay immune reconstitution. So now graft manipulation is focused on eliminating selective types of T cells to reduce graft versus host disease, but to maintain their ability to fight infections and preserve the graft versus tumor effect. So what would you put in a graft? If you were going to go into the lab and sort the cells from the donor into different buckets, what do you want to give back the patient? What do you need to give them so they recover their blood counts? Stem cells. So you definitely want some stem cells in that graft, right? Because you want them to recover their blood counts. What else do you want in there? Yep. You want some types of T cells. You want T cells that have memory to prior viral infections in particular. You want T cells that might recognize the tumor. And you want to probably minimize the number of cytotoxic T cells. Those are most responsible for graft versus host disease. So that's where the work in the field is going now, is to try to take those donor cells to the lab, sort them in different buckets, and give back all the things that you need for that person to be successfully treated and try to minimize some of the risks. And that's what we just talked about. Acute graft host disease treatment, the first is corticosteroids. If that doesn't work, we know we're already in trouble. So steroid refractory acute graft host disease is a problem for us because that's the best drug we have, and if that doesn't work, we're in trouble. So this is the problem with graft versus host disease. You provide immunosuppression to prevent graft versus host disease, which increases your risk of infection because you're suppressing the donor immune system. Infections trigger graft versus host disease. The way you treat graft versus host disease, you give more drugs to weaken that donor immune system. They're now at higher risk for infection, and death is almost always secondary to a combination of graft versus host disease and infections. So this is a spiral we try to stay out of. Right? You guys are hanging in there well. Again, I apologize. I'm going to skip this in the interest of time because none of you are directly caring for these patients, so you probably don't need to know about electrolyte management in somebody with a lot of diarrhea. It's important. Chronic graft host disease, if it's going to occur, typically occurs after the 100-day mark. So acute graft host disease is the first 3 months. Chronic can develop any time in the first two years. It ranges in incidence from 20 to 70% depending on a lot of factors like the recipient age, the donor age, the type of the graft. It looks very different than the acute form in that it can affect almost any tissue in the body. So the symptoms people have are going to depend on what tissue is involved. And the incidence of chronic graft host disease is increasing, and that's directly correlated because we're increasing the age of the recipients, right? Used to be 45 was the cutoff, now we're into the 70s. This is just looking at time course, and acute and chronic can overlap with each other. There's de novo chronic graft host disease. They had no prior acute, and they developed chronic. There's quiescent, so they had acute, it was successfully treated, then they developed chronic, and progressive. They go right from acute into chronic, and that's a poor prognostic feature to have progressive chronic graft-versus-host disease. And these are the most common sites affected, and the gray is for those that receive a bone marrow graft, and the blue is for those that receive a peripheral blood graft, or from the peripheral blood. And you can see almost exclusively, if we collect from the peripheral blood, the risk of chronic graft-versus-host disease is higher. So one of the factors that a physician is going to look at in selecting the graft is this risk of chronic graft-versus-host disease. We also know, though, for people with advanced diseases, so they're maybe not in remission, that they have a lower risk of relapse if we give peripheral cells. So in that setting where you have a patient at high risk for relapse, the physician may select peripheral blood to get a better anti-tumor benefit, but knowing they're increasing their risk of chronic graft-versus-host disease. If they're a good risk patient, less likely to relapse, then you might want to do a bone marrow graft. It's going to take a little longer up front for them to recover their blood counts, but you lower the risk of chronic graft-versus-host disease. And chronic graft-versus-host disease is the single most important variable impacting quality of life in transplant survivors. I just said that. This is another cartoon. This always happens in the middle of the night. For the nurses, if there's nurses in the room, you know this is what happens in the middle of the night. Risk factors for chronic graft-versus-host disease include any of those for acute, the use of peripheral cells, and prior acute. And poor prognostic features for chronic graft-versus-host disease are those that have more than 50% skin involvement, a low platelet count, and progressive onset, where it goes right from acute to chronic without interruption. Infections are the leading cause of death in chronic graft-versus-host disease because, again, the way you're treating chronic graft-versus-host disease is more immunosuppression, trying to tamp down that donor immune system, putting them at higher risk for infections. So in pulmonary infections after day 100, the 50% incidence in patients with chronic graft-versus-host disease and about half that in patients without chronic graft-versus-host disease. So we do a lot of antimicrobial prophylaxis. So we try to prevent infections as we go on. Viral infections, so we're worried about zoster or shingles. Annual flu vaccine. If they're on steroids, we want to provide fungal coverage. And if they get recurrent, particularly sinus infections, we also provide bacterial coverage. And because chronic graft-versus-host disease can affect any tissue, you need a lot of different specialists to help you deal with the different systems involved. Prophylaxis. Studying chronic graft-versus-host disease has been a real challenge because after day 100, if the patient's doing well, they're typically going home. And they're cared for by their hematologist, and they're seeing us maybe once a month for the first year. And by the time they've spent 3 months at Stanford, they don't really want to come back to Stanford every week to be part of a clinical trial, right? So you all know clinical trials can be a real burden to patients in terms of visits, testing, et cetera. So they've just spent 3 months here, and they just got home with their kids. Trying to convince them to enroll in a trial where they have to come back to see us frequently is really hard. So it's been much harder to study chronic graft-versus-host disease and make inroads into the treatment for that reason. And corticosteroids, like in acute graft-versus-host disease, are the mainstay of therapy. And then there's all sorts of other second-line agents that we use. So late complications, we just talked about chronic graft-versus-host disease. That's a misnomer. We did not. I just talked about chronic graft-versus-host disease. Cataracts. If you get radiation, total body radiation, you've got about a 20% risk of cataract formation, which is a clouding of the lens of the eye. That's a fixable problem. It's an outpatient surgery for most people, but it's something they might be dealing with down the road. In children in particular, we have to think about growth and development delays. So if we treat them as children, we want to make sure that we're following them so they go through puberty normally. Endocrine problems, hypothyroidism occurs in about 25% of patients who get total body radiation. Infertility, when people are treated with myeloablative conditioning, high-dose chemotherapy and radiation is almost a certainty for both men and women. And so if we're treating young people, that is a big loss in their lives early on before they've finished their childbearing. Women, if they're over the age of 25, will go into menopause early. So if you treat a 30-year-old woman with acute myelogenous leukemia, she's going into menopause about 20 years ahead of schedule. And there are other problems related to the woman's health with early menopause. Subsequent malignancies, the irony is the things we use to treat cancer can sometimes cause cancer. So we know that people have a lifetime risk of some other type of cancer as a result of the therapy we've given them. And that's a bitter pill to swallow, especially if you give somebody an autologous transplant for their lymphoma and they come back to you three years later with myelodysplastic syndrome as a result of what you've done. That's a toughie. And of course, relapse disease, as we know, remains a major cause of death. So this is looking at almost 1,100 recipients of allogeneic transplant who were more than 10 years out, and the risk of subsequent malignancies was 9% if we treated them for AML, 11% for ALL, 10% for non-Hodgkin's lymphoma, and 12% for severe aplastic anemia. And then the risk of solid tumors is threefold higher in survivors that are more than 15 years old post-transplant. So it is indeed a real risk that they assume. So, okay. How would you treat, this goes to your question, how would you treat a 40-year-old male with AML, acute myeloid, and first CR? So the first question is, do you think an auto or an allo? Allo. Okay, I agree. So you could do an auto, and if they have advanced disease, they have maybe a 20% chance of success, earlier better, but, and maybe an option if you don't have a donor. But I agree, I would use allo. And what kind of cells do you want? Bone marrow, peripheral blood? Bone marrow? Why? Who said that and why? Why do you want, Janet, why do you want bone marrow?
Well, they were able to achieve the first CR, then we're not so concerned about the relapse.
Perfect. I agree. I would use marrow. And then what kind of preparative regimen? Really aggressive, not so aggressive? I do ablative. This is a young person. He's in first CR. His best chance of long-term disease-free survival is if we hit him with everything we got. Okay, so myeloablative conditioning with bone marrow graft. And he has about a 65–70% chance that he will live to be an old man. That's the goal. We want to live to be old people. Okay, how would you treat a 62-year-old woman? Same disease, first CR. Auto, allo? Allo, okay. Can be an option, but not. What kind of graft do you want? There's no right answer. I mean, there's maybe better answers, but there's no right or wrong.
I say reduced intensity, but we don't know any other comorbidities at this point.
Yeah. So I would agree, reduced intensity, because she's over 60. She's going to tolerate that a little better. She's in first CR, so she's got a remission. We've got good disease control. We're going to give her some anti-tumor benefit from the preparative regimen and the graft versus tumor. And maybe because she's 62, I might go with a peripheral graft to get her engrafted a little quicker than bone marrow to reduce some of her risks of infection during the upfront portion.
I thought it's primarily on donor to decide, right? So it's
Yes, the donor also has a say, absolutely, absolutely. We may want that, and the donor may say, no thanks. Okay, I think I have one more. So now we have a 59-year-old male with same disease, but he's an induction failure, meaning he's got active disease. Auto? No, absolutely not. He's got active disease. So that's not an option. So we're going to do an allo. What kind of cells do you want? Peripheral cells, right? Because there's more T cells, you're going to have a better graft versus tumor benefit. This guy's got bad disease. We want to give him every chance we can. And how intense do you want the preparative regimen to be? Ablative, yeah. He's 59. If he's otherwise healthy, he's going to tolerate that. And we need to be as aggressive as we can because his disease is not in control. There is a higher risk of sinusoidal obstructive syndrome, a liver complication when you do ablative versus reduced intensity. But the incidence is about 21% and fatal in about 3 to 4. So I think you would take that risk.
In this case, would you consider an allo-identical transplantation, thinking that it will help even more for the graft versus
Yep.
leukemia?
you could do, you might only have a haplodonor, and in that case you could still use peripheral blood or bone marrow. Yep, yep. So we're winding up quick. On a scale of 1 to 10, 1 being poor, 10 being excellent, what's your quality of life? You don't have to share, just think about that for a minute. What is your quality of life? So if there's anybody 3 or below, we can find a psychiatrist. Right? So that is a very subjective question, right? Each of you thought about different things, right? Some of you, maybe you're worried about your kids. Some of you may have financial concerns. Some of you aren't happy in your job. You thought about relationships. You thought about your health. You thought about a lot of different things to answer that question. And I hope all of you have a good quality of life. But we ask our patients that post-transplant. And at 1 year, allogeneic recipients told us their quality of life was 8 or greater. So that suggests that subjectively, they're pretty content with where they're at. Right? And that's important to us because sure we want to cure them, but we also want to give them back a life that's satisfying to them. So there are a lot of things that we can think about. We can think about our physical well-being, our psychological well-being, spiritual, social. So there's a lot of things that we might think about when we try to answer that question. And the weight we put on those different variables will be different amongst us. So Dr. Thomas, who won the Nobel Prize in Medicine, Dr. Bluma, who started the program here, and Dr. Foreman, who took over Dr. Bluma's program at City of Hope, said that a successful program is always a team effort. Nurses provide bedside support, complex management of protocols, but bear the burden of emotional support through transplant. And they believe without a strong nursing team, the entire program is jeopardized. Okay. And of course, my bias is I'm a nurse, so I like that quote. And this is our 29th reunion. All these people have floral lays on, which indicates they're at least 10 years post-transplant. And there's a couple in there that are beyond 30 years now. And I believe that's my last slide, and I got 1 minute to spare. Questions, thoughts, concerns?
There's a lot of research coming out about the microbiome and how important it is, and I think there was a clinical trial done at Duke where they were transplanting patients in their home because of the importance of the microbiome and being in your own space versus coming into a hospital, which can kind of be sometimes cleaner, sometimes dirtier, but different in terms of the bacteria and everything that's kind of around. I don't know what the results of that study were, but wanted to just ask if there's additional research going on in that space and what they're finding about how important your home environment is and where your body is used to being in a situation where you're obviously removing an immune system and
putting in a new one.
Starting a new one.
Yeah. So we are doing a study with the microbiome led by Ami Bhatt. If any of you work with Ami Bhatt, she's wonderful. And she's actually moved that to a national trial. So a lot of transplant centers across the country are participating in that study. And so we collect a lot of poo, lots of poo. And you should see the contraption we send patients home with to collect their poo. But anyway, the research is interesting and they're finding different things. The problem is that by the time they get to transplant, we've already profoundly altered their microbiome because during their upfront therapy, they were likely on a lot of antibiotics. They were likely hospitalized. So we don't know that we're starting with their normal microbiome at the beginning. There's a lot of hopes that we might learn something about the microbiome that contributes to graft versus host disease of the gut and a new treatment avenue. So there's a lot of active research. None of it's ready for clinical practice yet. Yeah. Other thoughts? So the famous story about the microbiome is a mother who never had trouble with her weight, had recurrent C. diff infection, so she had a fecal transplant from her daughter. Her daughter always had weight problems, and after her fecal transplant, the mother always had weight problems. So there's a lot about the microbiome that we don't yet understand and how we can use it clinically. But anyway. Well, you've been very attentive, quiet, but very attentive. Thank you.
Thank you so much.